Um,
Yeah, we could see your whole screen.
okay. Just gonna share. What can you see now?
Yeah, we're good.
You're good?
Yeah.
The welcome page.
Perfect.
Oh yes, Roylene, you're moderating. I forgot.
Yes, I am. So I said we couldn't have any dogs barking in the background or garage doors opening.
That's true.
Yeah.
I have the live pause, so we're good to, just gonna send out the link now.
Barb, we've never officially met. I'm Roylene. I'm the manager of programs with the Algoma Ontario Health Team.
Hi, Riley. Nice to meet you.
Nice meeting you.
This is my first Zoom with my face actually on screen. So just getting used to it. I've participated in a lot, but never had a camera on my equipment. So I was always the ghost in the, in the black box.
Michelle, did you get a chance to get your hair done? I can't see it. Oh, good. I'm happy you were able to get that time for yourself. Cassandra, you would know best, but I'm wondering if everyone should come off mute for a sec just to say something quickly so we know that we can hear everyone okay, especially before we start our updates.
Sure, yeah, maybe Michelle, Aaron, and Jeff. Oh, we already know Jeff can hear, but we'll do a quick
We
test.
can hear him, yeah.
Can you hear me okay?
Hello, can you hear me?
Sure can. Thank you both. Just makes me a little nervous.
Technology, eh?
Yes, always. You'd think by now, but I don't know. There's something about it. Just have no control over it, right? Hello and welcome to those of you who have already joined our live stream. We're just going to wait a minute or two to allow others to continue to join before we jump in and get started. I am cognizant of the time, and so I would like to begin and welcome you to our last Project Percolator of 2023. This has been our largest registration to date. I'm looking very forward to keeping this momentum going as we roll into the new year in 2024. To begin this meeting, I'd like us to acknowledge that the land we are gathered on today is the traditional lands of the Anishinaabe. We are located on Robinson Huron Treaty of 1850 territory, a territory traditionally called Bawading, in reference to quick-moving water of the rapids. This territory is rich in history and resources, as we see all around us. The Anishinaabe recognized how important this land was for bringing people together, and here we still gather. It is our duty and privilege to be stewards of this land, and we reaffirm our commitment to honoring the First Nations, Inuit, and Métis people of Turtle Island. It is my honor to call this beautiful community nestled between majestic Lake Superior and Lake Huron my home. I'm Roylene. I am the Manager of Programs with the Algoma, Ontario Health Team. Again, thank you all for joining us. Just to review the session format, we are live streaming via YouTube, and we will proceed with in-person format in 2024. Please remove the old meeting series from your calendars, and if you have any questions for the presenters during this session, you can use the YouTube chat function or email info@algomaoht.ca. We have a relatively packed agenda today, as you can see. We've done our welcome and introductions. We'll move on to our spotlight presentation with some project updates after that with our transformation office team with the Algoma Ontario Health Team, and a briefing on some of our upcoming events. Who are we? That's the question, the million-dollar question. The Algoma Ontario Health Team is a team of local professionals and organizations and community members. We aim to create a network where citizens in our community will have access to the right care, the right team, and the right care setting when they need it. The goal is to have individuals experience seamless transitions throughout their care journey in a system that's understandable, digitally enabled, and collaborative. I'd like to take a moment now to introduce Barb Forrest. Barb is our spotlight presenter today. She is joining us from Seniors Mental Health Services at Sioux Area Hospital. Thank you, Barb, for taking the time to join us and share your knowledge.
Shall we go ahead?
Sure, go ahead, Barb. You can see
Great.
the screen, okay?
Great. Thank you so much for having me speak to everybody today. I have quite a bit of information, so we'll just get to it, and I certainly welcome questions at the end of it. So we can just go ahead and jump in. So wanted to start a little bit of an explanation, a broad explanation about our care model. And we are a community-based consultation for older adults who are having mental health concerns. And we classify older adults 65 years of age and up. I do put with some exceptions in here, and we can get into that, and I can answer questions about that later on. We do something that is called biopsychosocial assessment, which means we look at a broad realm with individuals, so medical issues, relationship issues, functioning issues. So we try to cover a very broad spectrum when we're doing assessments with people. Supporting older adults and their caregivers in developing a treatment plan. We assist with referrals, connecting people to resources. We're responsible for arranging geriatric psychiatry locum consultations. We have limited follow-up on a case-by-case basis. So the intent is not intensive case management, but consultation. So identifying issues and needs and helping people navigate through that so they can have improved quality of life and symptom management. And it's kind of what we call a shared care model. So we do a consultation. That information is shared with their family healthcare provider, and who the expectation is that healthcare professional will be following the recommendations that are made by the geriatric psychiatrists. So that's kind of broadly in a nutshell. We can get to some further details on next slide. So having said that, people over the age of 65, that's a lot of people. So who do we actually see? We have a very wide variety of issues that we help people through. So these are some examples from the Canadian Association for Geriatric Psychiatry. It's a paper that describes in details what a geriatric psychiatrist does. So these are a lot of the things that we see in our services. Individuals who have late onset depression or complex and severe depression. So they may have had depression through most of their life, and in the aging process there are things that become more difficult, more complex, and so they come to us for some help. Treatment resistant depression, and all of our mental health interventions include suicide risk assessment, because that can go across all mental health diagnoses. Behavioral and psychological symptoms of dementia. Some of the clients involved in our service do have that issue. We help them through that. Primary dementias that present with prominent and early psychiatric symptoms. So some individuals who are developing dementia will have things like psychosis, maybe hearing things, seeing things. So we help individuals get treatment for that. Alzheimer's dementia presenting in those under the age of 65, it's a little bit more unusual. Our geriatric psychiatrists can help with getting diagnoses around that. Also things like late onset psychosis. So some individuals may be just doing fine through most of their life, and for whatever reason, brain changes, aging, what have you, have psychotic symptoms later on in life. And we can go to the next slide. And more types of situations that we help people with are complex presentations of delirium. So those are medical situations where people have difficulty recovering from, and they may have psychosis, confusion, disorientation around a medical issue, and it's just difficult to get that resolved. So our psychiatrists can help with that. Psychiatric complications of cerebrovascular accidents. So that's very commonly seen in things like post-stroke depression, which we help people in that situation as well. Psychiatric complications of neurodegenerative disorders. An example of that would be someone who has Parkinson's disease and may be experiencing depression or struggling with difficulties around their treatment for Parkinson's is actually causing some symptoms of psychosis, and trying to navigate through that. Also individuals who have bipolar and schizophrenia. late onset or complications due to aging and other medical conditions. So people may have had these diagnoses and have managed, but through the aging process, the body changes. We need to tweak the medications. We need to look at some other things. Maybe there's changing cognition in there as well. So we help people through that. Excuse me. We also have individuals on our service who have intellectual disability with complications related to aging. There is an association between Down syndrome and dementia. So some of our clients are those individuals, and overlapping all of these in any way can also be substance misuse disorders. It could be the primary problem, or it's linked to other mental health issues. It gives you an idea of the clients that we serve. And we can go to next slide. Other clinical situations that we provide geri-psych consultation for is polypharmacy and related side effects. So sometimes just older adults that come to us are just on way too many medications. That needs to be streamlined, and sometimes it's just what's causing the problem. And our psychiatrists are very good at weeding through that. We also get referrals to review psychotropic medication use. So that's the mental health medications, or a practitioner is considering the use of that type of medication, but is concerned because of the client is older, they may be quite frail, and they want an opinion on that. Or we get referrals for individuals wanting an opinion on ECT use, which is electroconvulsive therapy, in older adults who are frail and or with dementia. And again, our geriatric psychiatrists are very good at giving opinions around how to treat that as well. Okay, next slide. So our process works kind of like this. Referrals we receive from any source. So can be a neighbor, can be a family member, can be the person themselves calling us up to make the referral. Each person is contacted to complete an intake, and they speak with the clinical staff. So we do risk assessments and referrals at the time of intake as needed. And we like to do that because we can try and provide a bit of service right away. Sometimes it's helping someone navigate through the system. We usually inform people of what our process is, what the next steps are, and explain how long the wait lists are. And we do have a priority system, so we try to see the most urgent people as quickly as we can. When the assessment's initiated, it takes place in the location of the client's choice. So it could be in their home, could be nursing home. If they prefer to come into the office, that's okay as well. We do it as a face-to-face contact. Most of the time, on rare occasions, it will be more of a telephone. That's usually by the client's choice. Results and outcomes are shared, with the client and within their circle of care. And we have these discussions on who are we going to share the information with and what purpose is this information going to provide? How is it going to help you? And then working with the client to develop a treatment plan. So it's our broad process. Okay, next slide. We also schedule all of the appointments with geriatric psychiatry. That's all coordinated through us. We do the booking, we provide follow-up. So each client that comes through our service is attached to a clinician to be their person for questions and follow-up. Let's see. Individuals that don't require geriatric psychiatry consultation have some limited follow-up with us. This would be someone who, has some concerns around their mental health. They want some assessment. They are able to deal with their issues through their healthcare provider. They're not necessarily needing geriatric psychiatry consultation. but there are things that they want to have addressed, and we can help them through that. Our current roster is Dr. Mark Lockman, Dr. Alvin Kang, and Dr. Christina Bochter, all coming from the Toronto area. And I just put at the bottom that we don't have the capacity for intensive or long-term case management. That's usually a very common question that's asked. And as the slides come on, you'll see why. Okay, we can go to next slide. Great, thank you. So our interventions, what do we actually do? We do the assessment. Sometimes people are connected with a geriatric psychiatrist, someone they just stay connected with us. And we would provide, I guess how we would describe it as a brief CBT sessions, and CBT stands for cognitive behavioral therapy. And we put sessions in brackets because we wouldn't do necessarily a course of therapy like hardcore 8 to 10 therapy sessions with every person that comes through. It's sort of tailored to the needs of the person. And when we're doing it, we're providing health teaching, strategies for symptom management, behavioral activation in our follow-up appointments. Some people have already had therapy and they want to just sort of refresh and discuss the interventions just so that they can continue going. Some people just need referrals to other services. It really depends on the case at the time. We work hard to engage caregivers throughout the treatment plan and process. They're very integral to the wellness of the people that we treat and help and serve. So a lot of our time is also spent with caregivers. We send referrals to various agencies, so like the Seniors Drop-In, private therapists, support groups that could be through the Alzheimer's Society or a grief support group through VON. We refer people to home and community care, meal plans, grocery delivery. So all of these services, addiction services, anything that the client is able to access and would help throughout the treatment plan, we try to connect them there. On occasions, when we have the space and the time to do so, we offer 2 groups for people who come through our service. One is called Blues Busters. It's a 6-week educational group for older adults. They're usually newly diagnosed with anxiety and depression. So there's a lot of teaching that goes along with, okay, what are you dealing with? What is this all about? And they come for 6 weeks and get some information and do a bit of sharing, with other people who are going through the same thing that they are, and find it very helpful. Another group we offered is through myself. I call it CBT Gold. It's based on a support group that was developed in Halifax. And it's a 9-week course for older adults who've been involved with our services, and they were looking for further treatment for anxiety, depression. So they would usually go through the Blues Busters. They get an understanding of what anxiety, depression is, and they want to do more focused treatment type therapy groups. So we're able to offer that on occasion as well. And next slide. So our partners in care, of course, are our clients, family caregivers, professional caregivers across all health social service agencies. So the hospital, Behavioral Supports Ontario, Algoma Geriatric Clinic, geriatric emergency management at the hospitals, healthcare providers, staff and residents in long-term care facilities and retirement homes, paramedical services. So whoever is in touch with that client, we consider them our partners in care. Okay, next slide. I wanted to add a little bit of the prevalence so that our work with older adults and mental health comes a little bit more on the radar in terms of because of the demographics and the prevalence. So just saying that people age 65 and over make up 20% of the population by 2037. This number will increase by 68%. A lot of older people, myself included, we're getting there. And just bringing some information from the Mental Health Commission forward, 99.8% of people in the age group of 65 to 74 having some issues regarding mental health. This is 7.6% in 75 years of age and up, and rates of as high as 40% in long-term care. So that's really, really huge. And we network with long-term care facilities quite frequently. And next slide. Just to give you an idea of our numbers and the reason why we can't do intensive case management with individuals. So currently we have 190 people on our active caseload. So these are all people who have gone through assessments, waiting geriatric psychiatry appointments, or have had geriatric psychiatry appointments, need some follow-up. So we're kind of following them along to sort of get some stabilization going. There is 192 people that are on the wait list with a completed intake. So all these people have been contacted, notified the referral has been received, and what our process is, and hopefully some preliminary referrals and support have been made at that time. And currently, at the time of November 9th, 19 people were waiting to be contacted for intake. We get an average of 30 referrals a month. So just to give you an idea of numbers. And next slide. Some more numbers. Okay, so this is just dealing with our wait list. So the 192 people on the wait list, 81 of those are just waiting for us as clinicians to see them and do an assessment. 111 are waiting for us and geriatric psychiatry. So it kind of gives you the idea of how many people coming in referral that are really wanting and needing and referred for geriatric psychiatry. So over the years, that number of requesting psychiatry consult has really increased. And next slide. So just a shout out to us. I wanted to put a slide in what our needs are, and essentially, increased full-time equivalents to respond to the needs as indicated by our referrals, demographics, and population projections. So in 2004, there was benchmarks published in the Mental Health Commission indicating 5.5 FTE geriatric mental health professionals per 10,000 older adults. And that's just 10,000 older adults in general. It's not 10,000 older adults with mental health issues. So I don't know if we're looking at 20%, or I had a colleague of mine say, well, how many people in Algoma are over the age of 65? I don't know, we came up to maybe 30,000. I'm not sure. I might be off the mark here. So, gives you an idea of where we're at in terms of FTEs and what the benchmarks are suggesting. And, we all know that we don't get funded for benchmarks, but we know that they're out there. We have a guideline. And our current state is 3.5 FTEs. So there's myself, full-time social worker, 2 full-time RNs, and a part-time occupational therapist. So I've been with the service for a very long time, over 30 years, and our service has increased by 1.5 FTE in 30 years. So next slide. And I just wanted to end off with this little thought about how well are we tending the garden. This came from a statement with the Canadian Coalition for Seniors Mental Health National Seniors Day, October 1st this year. And I love gardening, so I liked the analogy, but I think it's quite powerful. Your mental health is like a garden. Sometimes conditions are nearly perfect for steady growth and flowering. The other times conditions can be challenging with too little water, too much shade, or scorching heat, but there's always something you can do to tend to your mental health and keep your garden growing in all seasons of life. So I think it's important for all of us to ask ourselves how well are we tending the garden, our own garden, and the service that we're providing, and ask ourselves, how well of a job are we doing right now, and that we know that we can do better. But just want people to, think about this in general, and I'm open to questions.
Thank you, Barb. That was very informative. We will open the floor up to questions. If you're unable to pose your question in the chat, please send us an email again at info@algomaoht.ca. And Jeff, by all means, you can take the floor and ask Barb a question.
Awesome. Thanks so much for that presentation, Barb. I feel like I've heard so many great things about seniors' mental health in the community and the services that you guys provide. And now I feel like I have some more information on what that actually looks like. So I have a couple of questions. So I'll ask the first one and then maybe let someone else go, and then maybe we'll circle back to my other question. So my first question is, what does a successful patient outcome look like? And I know that's a really broad question because it's probably case dependent. You're probably seeing such a wide variety of conditions and patients, but is there, a way that the effectiveness of an intervention or the care that you guys are providing is measured, or maybe any success stories or positive outcomes that you'd be able to share, obviously without any patient information?
Sure. Yeah, great question. Thank you. Over the years, we've toyed with the idea of how do we measure success? How do we know when we've done well? And, we've looked at things like quality of life scales, all that, that kind of thing. I guess sort of where we evolved to, or how we think of it now, is quite simply asking the client themselves and the caregiver, do you think things are better, and what's better? And that's kind of it. Like, we know when we've sort of got to a point where we think we got a handle on this, like we think we can deal with this. Sometimes there's not a lot of change in the situation, or the gains are very small. So there's a bit of symptom improvement. Sometimes there's a big symptom improvement. So like you said, I think it really varies across people that come through our service. But usually when the person says, I think I'm doing a bit better, and their caregiver goes, I notice a difference. And then we kind of talk about, can we make it even better? Like, what else are we missing? What else do we need to do? So we do that's kind of our follow-up. Yeah, we usually know because they'll say, well, I don't think we need to see you anymore. I think we're okay. Or it may be that the situation stays the same, but the people caring for the individual say, I have a handle on this now. I understand, and I know how to help my loved one. So they sort of, the anxiety or sort of figuring out what's going on and how do I deal with this, the caregiver gets to a good place there, and they say, I'm good. And if something goes wrong now, then I will call you. That's sort of like that. Yeah.
Awesome.
Raylene, we have a question in the chat, so maybe I'll just go ahead and read it next.
Yes, please. I didn't see one. Thank you.
No problem. Okay, so Debbie Greystone says, who follows those patients who do not have a primary care provider?
Mm-hmm. So we do. Helping individuals with no primary care provider who require geriatric psychiatry becomes a lot more complicated than it has in the past. We do try to work with people getting referrals even through walk-in clinics, so we have some kind of referral. We do have some patients who we're now providing, I would say, on the odd case, more direct care. That's really not what we're supposed to be doing, but we can't leave these people in the lurch. That's all I can tell you. So we do our best to follow them. So as a clinician, just seeing how they're doing with their symptoms. And if we have follow-up that's available from the locums when they come, we try to get those people in for follow-up. It's extremely difficult, very complicated, and at times very frustrating. Sometimes individuals have to go to the emergency department as well. And we try to help people avoid that, but sometimes it's unavoidable.
Thank you.
Sandra, are there any more questions in the chat?
None that I can see at the moment.
Okay.
Just go into the info. No, nothing yet. So maybe Jeff, you can.
Yeah, sure. I'll come back to my other question. Okay.
Great, thank you.
Awesome. So, yeah, so my other question was, are there any efforts made to raise awareness about mental health issues among seniors in the community? And obviously, you talked about the structure of your team, and you guys are obviously only, 3 or 4 people. So, I'm just wondering if there's anything out there like educational programs, aimed at reducing stigma and increasing the understanding in our community of these issues. And I ask that because, I know for the older generation, through doing some work around healthy aging with the OHT, is that there's that stigma and that hesitance to seek services oftentimes within that population.
Right. Thank you. Yeah. And an excellent point. Over the years, we've been invited to events, things like Seniors Drop-In Center, go and do a chat with people that are coming for lunch and learns, and health fairs and, that sort of thing. So, over the years, we've participated in that sort of thing. I think there's a lot more, definitely, that, can take place. But for us, it's basically, someone needs to get a hold of us and say, hey, can you come and do this? And we like to do that. We enjoy doing that, and figure it's pretty important, and appreciate the opportunity today for sure. But yeah, you're right. I think, there's still certainly a lot more that needs to be done ongoing. Seems to be sometimes it goes in a cycle. You get a lot of people in some area that's interested in, getting this done, and then they make it happen, and then, other things take priority. So.
Marlene, I have 2 more chat questions here. Well, so we'll do those maybe, and then we'll jump over to Michelle because I see she raised her hand. Okay, so Donna Latulip, board chair at Algoma Manor. Is there any work with EMS or OPP?
EMS, I'm thinking like paramed. Yeah. We do get referrals from Sioux Paramedicine, who I know that they have targeted programs to older adults. So when they're seeing them and then they have questions or concerns for us, they'll actually make referrals to us. And we're definitely open to receiving, referrals, information from any source. So it could be from OPP if they're doing an intervention with somebody and have a concern about an older adult. They can certainly make a referral.
Thank you. There was a follow-up there too. What about anything with the Alzheimer's Society?
Yeah, we share referrals back and forth. So if someone goes for cognitive assessment at the Alzheimer's Society and they're concerned that there's more going on just in terms of mental health, they can make the referral to us, and they do. Sometimes we have people in common, with dementia and other mental health issues. So we'll work closely with them. We'll send referrals for individuals for their services. So caregivers need to attend support group, or, promoting things like they have Mind in Motion, adult day program, that sort of thing.
One more from the chat here. Thank you. Thank you, Barb. Debbie Greystone, is the hospital the best environment for outpatient care? Where does this funding come from? Just thinking a collaborative relationship with a community partner might allow more capacity.
Okay.
Good question.
Yeah, probably a question for the higher managers to answer. Absolutely. I think when we started, most geriatric mental health programs were attached to hospitals, being a Schedule I facility, being able to access psychiatry, that sort of thing. So, I don't know. I mean, that's a question I don't think I'm able to answer.
That's it from the YouTube chat function, so maybe Michelle can.
My question was answered, so I'm going to make a comment that I really thank you for coming, Barb. I think focusing a light on the great work that you and your team has done over the years, and the demand will help initiate additional conversations around the need and what we might do as Algoma Ontario Health Team. So thank you.
Oh, you're welcome. I'd be very happy to be contacted in the future if you need further information or feedback on that.
And I think Michelle has completely summed up this part of our presentation. So again, Barb, we do thank you very much. And I do look forward to some future opportunities.
Great. Thanks for having me.
Again, if there are any questions that our participants think of, by all means, you can send us an email or pop them into the chat, and we can maybe send them to Barb's way at a later time. Now we'll move on to some updates from our Algoma, Ontario Transformation Office team members. You'll be learning more about mental health and addictions, roadmap work, system navigation, episodic access to virtual care, frailty ID, and patient family advisory committee. The team will take it away.
I can go first. So I'm really excited to provide an update on episodic access to virtual care. At the end, just for those who may not know much about this project, at the end of January of this year, Ontario Health teams were approached by Ontario Health with an expression of interest to design an episodic access to virtual care program. And the goal of this program is to support unattached patients with low acuity concerns better managed outside of emergency departments. That the model is to support patients to receive virtual online appointments with nurse practitioners. So that's the vision for the program. Funding for the design was granted to our region to move forward in early this year, and work really got underway in the early spring with the formation of a Northeast Episodic Access to Virtual Care Working Group. That working group is made up of primary care physicians, NPs, family health team, executive directors, individuals with digital experience, and patient advisor. The activities of this group that have taken place have been primarily an environmental scan of technical solutions, and also a review of models that were similar across the country to this model. The outcome of that environmental scan was the gathering of requirements into what's called a request for proposal, and that for a solution. So this fall, an RFP, a request for proposal for this solution was posted, and it is anticipated that over the next month that an evaluation of those request for proposal, the responses, will take place. In addition to this work, as part of fall surge planning, Ontario Health is actually also implementing an interim episodic model to virtual care solution. And this is going to be supported by an East region model that's already in place. And this solution is targeted to launch this month. And then for next steps for the Northeast-based solution, it's anticipated that the vetted solution will replace the solution that is to launch in December come spring of next year. So thanks for the opportunity to provide that exciting opportunity that is one piece of the puzzle in supporting unattached patients in the Northeast.
Thank you, Michelle. Who from the team would like to go next?
I can go next. Although, of course, the time that I have to be off mute, there's a plane flying above my house, so ignore that if you can. So hi, everyone. I'm Cassandra Lepore. I'm a transformation consultant with the Algoma Ontario Health Team. So I'm going to provide today an update on system navigation. Well, part of system navigation, I should say. So I am leading a working group of dedicated individuals focused on releasing a roadmap for navigating patients and caregivers and families through services relating to mental health and addiction. So we've been meeting over the past few months on a bi-weekly basis to really make some great strides towards releasing a roadmap similar to the one that the hospital released for stroke. So we know that mental health and addictions is not very, streamlined and linear as compared to a recovery of stroke. So it's been quite the process thus far. What we've done is we've really developed a list of resources that currently exist. We've identified challenges, opportunities, and we've also provided input into some provincial tools as well. So for example, Health 811 tiles, if anyone's familiar with that service, that's probably an update for another time. We've also reviewed a series of journey maps to determine features that we would like to include in our roadmap. We have also mapped some sample roadmaps against the roadmap to recovery from Ontario Health, using similar language to Connex Ontario. We've also met with the Innovation Centre and 211 North to really try and live pull some directories on our web pages. So there's been a lot of exploratory work to date, and I'm really excited to see where the group is going next. So what we'll be doing is releasing a resource guide, which follows, a continuum of services, which is really exciting. So we're hoping to have that released in the new year. And that's it for me. Thank you.
Thank you, Cassandra. Jeff, did you want to go next?
Sure.
Thank you.
Yeah, so I can't remember if I introduced myself earlier, but if I didn't, my name's Jeff Dorans. I'm Quality Improvement Consultant with the Algoma OHT. So for those who aren't aware, one of the main priority populations that the OHT has been focusing on since the beginning, a little over 3 years ago, are older adults living with frailty. So our community has a significantly higher proportion of older adults in comparison to other regions. So this was identified early on as, an area that we would really focus our efforts in. And so part of that is ensuring that older adults are able to age in place and enjoy a high quality of life in the community, living in the community. So a couple of years ago, we set out to pilot a frailty screening process in primary care to identify those older adults who could benefit from some intervention that would, again, as I said, help them age healthier in place in the community. So what's been done to date? So last year, we were able to successfully pilot a frailty screening program at the nurse practitioner-led clinic here in the Sioux. So we screened a pretty good portion of that patient population and learned a lot from that pilot project. So next steps, what we're working on right now is we're trying to ensure a way that we can sustain that frailty screening program in the nurse practitioner-led clinic, and also looking for opportunities to expand that frailty screening to our other primary care partners in Algoma. Right now, we are specifically working with our partners in East Algoma, the Huron Shores Family Health Team, to see if there's an opportunity to sort of work that into their clinical workflow. So that work is just gaining momentum right now. So again, really excited about what the future holds for frailty identification and the rest of our healthy aging work.
Thank you, Jeff. Erin, we'll move to you next.
Hello. My name is Erin Mulroney, and I'm the OHT Research Assistant. I've been facilitating the newly formed OHT Primary Care Patient and Family Advisory Council, also called PFAC. The PFAC consists of 18 dedicated community members who have begun to meet monthly with the aim of bringing the voices of patient, families, caregivers, and advocates across Algoma to the forefront of discussions on primary care. For the first few meetings, we have focused on building a strong foundational knowledge about the local primary care landscape among the community advisors, with presentations from some of our primary care partners. Last meeting, the advisors voted to adopt their new terms of reference as part of our progress on laying the groundwork for a sustainable group of advisors who contribute meaningfully to improvements in primary care. So there's a lot of excitement about the ability to listen to this diverse group of community voices focused on solutions, and a lot of excitement about their many creative ideas and insights into primary care improvements. Next, we'll be voting on PFAC member co-chairs and moving from laying the educational foundation towards project work, and hope to do a spotlight on the PFAC in the future here at Project Percolator. Thank you.
Thank you, team. Did we miss anything? Is there any additions we'd like to add? Those were our highlights for this percolator. If you have any questions, we do encourage you to put them in the chat, and we will be happy to answer them. We were on the road in October in Blind River, where we were able to attend and stream an education series hosted by the Huron Shores Family Health Team. So that was a wonderful experience, and hope to make our way to North Algoma at some point in the spring, and when weather permits us to travel that way. Cassandra, are there any questions in the chat, or are we okay to end? Okay. Well, thank you all for coming. We do appreciate your continued support and cooperation and partnership. Stay tuned, watch your inboxes for future invitations to come your way, and I look forward to an opportunity meeting you in person in 2024. Thank you.